delighted to introduce our keynote speaker, Dr. Wodchis, who will be discussing partnership to implement evidence-informed primary and integrated healthcare. Our theme of the day is using what we know, implementing research into practice and policy, and this presentation is going to set us up for the conversation on that theme for the rest of the day. We will be opening up to questions from the audience after the presentation, and there'll be some mics that can be brought around to you in the room. Dr. Wodchis is a professor at the Institute of Health Policy Management and Evaluation at the University of Toronto, and is research chair in implementation and evaluation science at the Institute for Better Health at Trillium Health Partners. His main research interests are health economics and financing and healthcare policy evaluation. Through his research programs, which include more than 30 collaborating researchers and as many trainees, Dr. Wodchis has led several studies examining complex needs of high-cost patient groups, the implementation and integrated care programs to address those needs, and evaluation for a number of integrated care programs in Ontario. So please join me in welcoming Dr. Wodchis. Well done.
And then great, thanks very much, and what a pleasure, and what a full room. I'm not sure we'd fill up a room with this many people in Ontario, and we have a few more people to draw from. So well done. I'm going to have a really great time here, and I'm not sure, I hope I set you up a little bit for the rest of the day, but I'm going to talk a little bit about the work we've been doing in Ontario and try and keep it pretty practical, and so what we've actually done. This may or may not be powered. It's okay, I got a keyboard. That's not powered either. How do I get these to go? Oh, no, we're not moving there. One minute. Well, I'll start off just by telling you a little bit about myself. Now it is? Okay. First off, I come here with no commercial interests. I received funding from the Ontario Ministry of Health and Long-Term Care and Canadian Institute for Health Research. I've received a number of honorarium, none from private sector, all nonprofits. I do some international consulting work. I'm at the University of Toronto. That's my main home. I also have a research chair in the health system at our highest volume hospital system in Ontario, Trillium Health Partners. And so, I spend my time with my family. Yesterday was Father's Day. I got most of the day with my family on Father's Day before coming out here. Summertime's coming. We can do a lot. I cycle all the time. And I like to travel, which is good because this is a job that comes with some travel. On the other side, when I'm mostly at home, I do some national, international work in the area of policy advisor, but I do a fair bit of that. I am an academic. I train PhD students. I train graduate students, and undertake a lot of research. And every once in a rare moment, I tweet. I'm a tweet. Yeah, there you go. Here is probably one of the more famous pieces of research that I've done. And what you see here on the left side is we looked at everybody in the entire population of Ontario. It was about 14 million people at the time. And we said, how much money do we spend on them? And we had quite a bit of work to be able to take everything we do and drop it down to each individual at any point in time, how much we're spending on them. So the population on the left, we ranked people in 1 year from $0 on the bottom to hundreds of thousands of dollars on the top. And then we said, and how much of our healthcare resources went into this? Different slices of the population. So here, top 1% of people in that left column, they consume 33% of our healthcare spending in Ontario. Top 5% is 2/3 of all of our healthcare spending in Ontario. So this motivated people to start paying a little bit of attention. And I was at a meeting on Friday, and people are still paying attention to this. I'll talk about some of the benefits and cons of that, but you know what? It's not just Ontario though, because George Kemper's here back there, and this is his data from Nova Scotia. Same thing. 5% of the population consuming 64% of your resources here in Nova Scotia. And this is physician and hospital care, I believe. So I'm going to use this as a background to say, what I'm going to show you is not only is going to be, some of it's going to be data from Ontario. I think you can say it probably happens the same way here in Nova Scotia. These are general population trends. What I can say, we've got international work now, study coming out with 7 countries, and Canada is actually slightly about the most concentrated of any of the 7 countries in that study. And we could get into a longer conversation. I'm done talking about cost concentration right now. I talk about other things. But it led to conversations with policymakers and how government thinks about its services. Because it's actually not only healthcare, it's social services, it's housing. Many other parts of government services go into a pretty targeted population. So when we brought this government, main thing I had to say, they're like, oh, wow, we need to do something about this. I'm like, well, wait, whoa. Actually, we maybe do, maybe don't. We have a high-tech healthcare system and it extends lives. You know, we do cabbages. We do cancer treatment. This is not cheap. It extends lives. We like to give people new hips and knees. People like to stay mobile and functional, and that's good for their health. That's not cheap. So healthcare costs money. So we probably don't want to stop all of our spending on the high-cost users. In fact, we want to keep doing lots of it, but maybe not all of it. Because one of the things we do is we treat people with specialized siloed services, very much organ or disease-based. And one of the things we've been looking at, and we looked at those numbers across time and said, okay, well, those acute events are mostly pretty short term. They're probably over, for the most part, within a year, even most cancer treatments. So how many people extend over? And we found about 40% of the people are extending over multiple years of high cost use, about 3 years out. And most of those people have chronic conditions. Most of them have multiple chronic conditions. And we have very few options to effectively manage people with multiple ongoing chronic conditions. And that's then been the space that we've been working in. So I actually think we can make possibly more efficient processes, but we keep doing cancer treatment. We keep giving new hips and knees. We keep doing cardiac surgery. But let's think about, we're designed pretty well to do that. Let's think about where we're not designed well and what really the needs are and where our opportunities are. And so now I'm going to talk about, this is my talk. That's just intro. I'm going to talk about the challenge of multimorbidity. And I talk about some of the best ideas to address the challenge and lessons from 3 tries at collaborating in Ontario and successes and failures along those. So this is about partnerships between research, policy, patients, and providers. And that's what I'm really going to flavor this with, is what happens when we actually try to do that to address this issue. Because this is an issue where that actually is needed to do it. And it is about partnering for evidence informed, so that's the part about some best ideas. So we, and I mean us in the room, everybody in Canada, most people in North America, all over Western European countries have a problem. Multimorbidity is increasing across all ages. This is data from Ontario, but trust you me, it looks the same here. And what I've got here is if you look at 2003, that gray in the background, that's the entire population of Ontario by age. So 0 to, we censor at 100 years old. That's got everybody just because the numbers get small. So you see there, baby boom, this is age at that point in time, 2003, we're in their kind of mid 40s at the peak, earliest ones being around kind of 62. Underneath there, we have people who have one of 16 chronic conditions. I'll name these in a minute, but they're your common ones: diabetes, hypertension, osteoarthritis. And we show the blue is people with 1 condition, red is people with 2, green 3, 4, 5 or more. And then we also did exactly the same thing out in 2009 and 2016. I'm going to put some scale on this for you a little bit. So about 70,000 people were the maximum group that had about 1 condition in 2003. And actually that didn't change a lot over the time. So getting 1 condition actually hasn't changed a huge amount. You will see, if you look carefully at the curves, that the blue is kind of creeping up a little bit in the younger ages. We're diagnosing more chronic conditions in earlier ages than we did a while ago. But what is really changing is the space above the line. And that's the people with multiple chronic conditions. And this is the peak in 2003 now shown by here. So 2 or more conditions in 2003, we had 25% of our population had 2 or more of these chronic conditions. And by 2016, it's up to 32%, 32.2. So we're almost at a third. We've gone from a quarter to a third in 13 years. That's a pretty big shift. And I'll show you why it's a very expensive shift. You will also see that the space above that red line is rapidly growing. And those are, that's 25,000 per age group, now multimorbid, that were not 13 years ago, and with 3 and 4 and 5 and more conditions, which comes with a lot of issues. Why? Because healthcare costs attributed to multimorbidity are substantial. We spend almost 70% of our dollars on people with multimorbidity. And in Ontario, that's about $36.5 billion this year. Hospital care remains a primary cost driver, but it is not only hospital care. And healthcare costs are more than simply additive. So I'm going to go back to our cost concentration curve again. And I say, what happens in multimorbidity? And Ked Tavorn had a paper just about a year and a half ago that similar idea, percent of the total population. Now on the left side are how many chronic conditions do you have out of our set? And none are in green. That doesn't mean you have nothing going on. It just means not in this set. And then people with 5 or more chronic conditions, only 2.7% of the population at the top, 20% of our healthcare dollars going, so 10 to 1. People with 2 or more chronic conditions, that's the quarter of the population. This was in the original data set based on the 2003 data. 68% of our healthcare dollars are going for these people. And I just saw a new paper out last week by some colleagues, Lauren Griffiths and others out of McMaster, where they actually looked at studies that have been done in stroke populations, diabetes population, and I think hypertension. It was a third condition. And they'd been done similarly, just looking at what the utilization patterns were for those conditions. And they've been published in separate papers, because that's how you do research, right? You publish in your separate diseases. And but they'd use the same methods. And so they pulled them together and they said, well, what's common across these? And actually the common thing across these is that the most spending and most resources were not for the target condition that they were looking at. It was for the comorbidities in all 3 cases. So I think that's pretty common. These are the 16 that we're looking at. And this actually looks specifically at how many in each of the conditions, how many people had that condition plus 1 other. That's the red space, plus 2 others. That's the light green. 3 others, it's the purple. Hopefully it's showing up same colors. Yep, thank you. And light blue, that's that condition plus 4 or more other conditions. And the white space that you see left are the people who only had that 1 condition and none of the other 16. So, asthma strikes a lot of kids. That's what they have. So the biggest white space there is on asthma. Mood disorders, middle-aged and youth, also in here with depression, mood disorders. Diabetes start creeping into the older ages. And here you see, now we're up to, with diabetes, less than 20% of the population having only diabetes. And by the time you get down to the others like CHF, renal failure, dementia, stroke, AMI, there's like hardly anybody only has these conditions, right? So the fact is that this is what people live with when we say they have chronic conditions, is they don't just have a chronic condition. They have multiple chronic conditions. But unfortunately, we don't have really good pathways for them. Not evidence-based pathways anyways, so it's co-design. One of the other things is, if we could pull together some disease pathways, maybe we could find some of the most common conditions, common pairings. So I'm sure hypertension, diabetes, gonna have something there. So what if we did that as a strategy? Now you might recall I showed you earlier how much of our fund spending is going on these people, and it's not just people with 2 conditions. So we need to think about, well, how do we work that with 3 conditions or 4 conditions? So we put these together. Actually, I'm just going to cut straight to the other detail here. So this is like the top 5 sets of people who have 4 chronic conditions, and these are the most prevalent ones. And this was in the 2009 data originally. So 20% of our population are in these top 5 clusters. To get to 50% of the cohort, we need to get 30 clusters. To get to 80% of the cohort, we need to get to 127 new guidelines that need to think about 4 different conditions. If we think about people with 5 or more conditions, it's our highest concentration of spending, right? These are the people, it's 10 to 1 on the dollars, 20% of our spending. Only 6% of that population are in the top 5 clusters. It's basically 1% per cluster. 243 to get to 50%. And if we want to get 80% of that cohort, we need 2,744 guideline sets. Anybody want to start that? And I had a PhD student who was going to try and start that. Yeah, I'm not kidding. That was her idea. She's like, how do we do this? Why don't we try it? I'm like, you are an MD PhD student. You want to get your doctorate and then go back? So we did something different. And now she's doing her residency in geriatrics. Okay, so one of the things we know is multimorbidity is increasing more rapidly than chronic disease. And this is evidence. Burden is high and escalates exponentially with the additional diseases. What we don't know is how much improvement we can make, because we really don't have good evidence-based performance measures here. We need to think a little bit differently about this space. I'm usually would go into continuity of care right now, but in the interest of time and partnerships, I'm going to skip that little bit and just say it's important. Okay, so what about the guideline space? So this is what clinicians have. This is what people at the front lines actually have to rely on for chronic disease care, is guidelines. Cynthia Boyd, who got me into this space in the first place, 2005, this article, because I was working in pay for performance and how we pay people. And Cynthia wrote this paper on pay for performance in the United States, and actually how it really wasn't going to help because of this. So her and her colleagues said, okay, we're getting marked on whether we deliver chronic disease management care according to guidelines, and we will get paid if we do that, and we don't get paid if we don't. Here's the problem. So they had a typical, she's a geriatrician, 79-year-old woman with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, chronic obstructive pulmonary disease, all of moderate severity. This is totally run-of-the-mill for geriatrics. It's even run-of-the-mill for primary care. So what happens with these guidelines? So here's what happens. 12 medications, 19 doses a day, drug disease and drug-drug interactions. And if they've got peripheral neuropathy, osteo guideline says, do weight bearing, diabetes says no. So these guidelines, and this is her and colleagues' assessment, do not provide an appropriate evidence-based foundation for assessing quality of care in older adults with several chronic diseases, i.e. most of our people. So the system has implemented evidence-based approaches to treat individual conditions, but these people have multiple, often duplicative, and too frequently conflicting or antagonistic treatments. And we lack an integrated approach to people with multiple and complex health needs. So that got me down a new path. And that's what I'm going to talk to you about, which is how did we think about some of the best ideas to address this challenge and working on ways to implement them. Looked for more evidence. We didn't generate a lot of this, but we started looking around. Two things I'm just going to highlight, and I think this will resonate with what I just saw. Patient-centered medical home, I see lots of components around that. We're doing work across this space, continuity of care I mentioned. Today I'm going to focus on the team-based care aspect because I think I can come up with like a coherent set of things. What do we know about patient-centered medical homes? This is evidence-based work. Is anybody here a doubter that patient-centered medical homes are a good idea? Put your hand up and I'll go through the slide. I'm serious, like if you want, I can go through the slide. There's a lot of references on the bottom, you can check out after. Okay, I'm gonna skip the slide. It's a good idea. International work. When we went to look for integrated systems, so a step up from patient-centered medical homes to more comprehensive integration with community-based assets, social services, we found less evidence, and so we went out and we did a series of things. First, we looked at some programs. There were a couple trials. Then we did a great project with support from the Commonwealth Fund. That's the one in the middle with King's Fund and our research network supported by the Commonwealth Fund. Cases from 7 different countries around the world of how they were working, the best programs in those countries. And then we've had some other reviews of work to date. And I'll highlight some of our learnings from these. You can go read these a little bit more if you want. We're still in this space. But one of the things we found is that they were local, but no national programs implemented. So we actually couldn't look to another system and say, how can we learn from a system? No, we actually had down to learn from programs, projects, local innovations, bottom up. Existing programs that have demonstrated micro-level integration, they centered on coordinated services. Primarily it was service integration. There's a little bit of functional integration, varying degrees of professional integration. Very few are at a point where they actually have organizational integration. And in fact, some of the examples that started in that space, like in Sweden, it took them 3 years longer than anybody else before they ever saw a patient. So maybe that's not the best place to start. And system integration has not been achieved in any country. So that's for sure. There are pretty integrated systems, but not nationally. There's no single best approach, for sure. Positive outcomes are achieved through a wide variety of approaches. Integrated care is high touch as much as it is high tech. Both can be very useful. I was looking at some of the abstracts. I don't know, I won't get to all of them, but there's a talk on like using digital health for remote access, right? Good use of digital health. Patient-centered focus enables the professionals and organizations to work together. But one thing we found, if you were to have this meeting in any of these countries, you would have fewer probably patients than we have in this room. In fact, UK is definitely starting to get ahead of the curve in that space, but not a lot, not as much as you expect. And how many primary care physicians in this room? That's about as many as we get in any international example, right? So 7, I think, I counted there, maybe 6, which is, thank you for coming. Because often not part of the teams. And a lot of decision-making comes down to primary care physicians in setting people, because that's where people go when they have health challenges. So integrating care, it's a bottom-up initiative. We need to do well, and we need to seed and foster local growth, because that's how it's going to happen. There isn't going to be a central Nova Scotia Authority integrated care model that gets spread and adopted across the entire province at scale, at speed. Not in the near future. People just don't work that way. That's what we found. It's not Canadians, not Nova Scotians, it's people. They want to do their own thing. They want to work with their partners. They have relationships that they need to leverage, and they need to be given vision. I'll come back to that, and opportunities to get there themselves. It is enabled by system-level priorities, funding, and technological supports. That's what people need to do work well. And it takes time, and I'm not going to talk a lot about building trusting relationships today. Give that talk on Friday, but we go nowhere without trusting relationships. And that's why it's local. Here are some of the components that we found of integrated care programs on an evidence-based review we did. These are 5 programs, North American programs that had pretty strong quantitative evidence base. I'm going to talk in here about only using this, I'll come back in a second, off that space. I'm going to talk about 3 projects that I've been involved in Ontario. I have a few more on the plate, but there's 3 really good examples, I think. One is about care transitions, one is about coordinated care, and a third is about specifically team-based care. And they all involved researchers, patients, providers, and policymakers. So that's why. And they focus on these 3 areas. We're interested in the space of building teams. So one is continuity of care and transition management. Second is individualized care plans. And third is interdisciplinary teams. So this and the patient-centered medical homes, like I only work if it's on that page. I don't work off those pages. And it just keeps us moving in the right direction for the kinds of programs we're interested in. So the transitions, so why did we get involved in that piece of work on transitions? Multiple chronic conditions. This is some work that we had done, pretty low level. We never published this, just informing policy and practice. This was people who had 2 or more ambulatory care sensitive conditions. So that's 6 common chronic conditions. And we said, that should be percent of patients with the number of providers, not percent of providers. So how many of those people had a visit with 1 provider in a given year? It was about 11%. That's that number on the far left. So what proportion of the population had 2? It was about 4%. And you see the highest, other than only 1, is 6 providers, different providers engaged in your care per year. But lots of people in the 20s as we went out, or a few people out there in the 20s anyways. Then we said, what are the number of different visits, encounters that you've had in the health care system? And I say 1 to 9 over the course of a year. That's the highest, about just under 30%, 10 to 20, 20%. And then it scales all the way down. There's 5% of people in the system that we found had 200 or more encounters in the healthcare system in the year. So I think coming back to our high-cost users, these are some of the people that, can you imagine? I don't think there are 200 business days. Like, hospitals are open every day, but primary care isn't open every day. These people are in more than every single day, 5%. So we're like, that's a lot of transitions. How many people here think transitions go really, really well? I'm going to skip a slide on evidence for care transitions improvement and go straight to PATH, PATH was supported by the Change Foundation, which is a nonprofit organization in Ontario. They put public policy interest in healthcare, and they're usually lately been working in the area of advancing particular areas of health system improvement. And this one was their first big one, 2011-2015 strategic plan around patient partners advancing transitions in healthcare. Very much about patient engagement, patient co-design. Evidence-based co-design was a real motivator for this program project. We were brought in to develop performance measures, track it, and do the evaluation as part of the partnership team. A couple of the things about this intervention that made it unique and new. They had something called the RISE team, which is Respect, Inform, Support, and Empower. And this was self-named by the people involved. It was 15 patients and caregivers who provided advice to all aspects of the project locally and got quite deeply engaged in all ways. Experience-based co-design workshops for 5 project teams, co-led by the patients and providers. The essence of the intervention, of the change in care, was something called My Health Experience. It was a digital tool on tablet and computer to monitor self-managed. People had sort of moderate, not little phones, but moderate-sized tablets. They could track their own goals and track their health conditions using this technology. And where's Tara? This is an originator prior to Carolyn's work on some things that we're still involved in using this tool in more very focused and targeted ways. Patients Canada was involved in the development and proposal and patient experience measurements. So we worked with Patients Canada representatives in designing what was going to be the measurement system on which we'd evaluate this program. That's not all patients, that's Patients Canada. Here is what we found. So this came out of their report, so I might have picked a different indicator, but they reported on one thing here. Please rate your overall experience of this visit. So people had live tracking. As soon as they went to a visit on their app, they could say, this is what we worked on, and they had 5 questions that they rated on that experience about whether they were engaged and involved in the decision-making, if their answers had been provided, and if that visit was due to not getting care somewhere else in the system. And then this experience question was one of them. You see, generally speaking, over course of time, things got better in overall experience. You can see that the sort of not satisfied options here are pretty well disappearing, diminishing, somewhat satisfied. The other thing, though, is that the project ramps up, and these little ends that are really hard to see at the top of the bars, but we put them there on purpose. It starts off with 13 ramping up to 25 people providing responses per month. Total people involved in this project were about 75 really engaged in this technology. And you see, so here the responses peak at about 65 in 1 month in January 15, and that was when everybody was finally onboarded. The whole program was live. It took that long to get it live. And then we see how many people are actually responding on this starts to dwindle very quickly after that, gets cut in half by the next month, 20 the next month, 19, 5, 9, and then that was the last month we had enough data to report. People just didn't care that much about reporting in on their providers' experience, their experience with their providers every single time. Did we ask the patients what they really wanted to do with this technology? No, we designed it and brought it to them. Next time around, we did something a little bit different. Couple of things. In 2012, patients were organized. We'd co-design measurement. We did continuous data capture. From my perspective as an evaluator, it was amazing. We had live data. So as soon as the patients hit the button on the phone, that data was in the database. I could access it immediately. We sent it out every Monday. So we collected the data up to the prior week, every Sunday, cumulative data the last week, and we sent out what we called the Monday report. So everybody went, like, we were used to having people get performance data 2 years later. Now we were within 24 hours on some patients' data. That hopefully made it much more actionable. So what did people do with it? Well, the project team reviewed it, but they didn't share the data. Anybody. No provider ever saw that data. It's people who actually could have done something about it. And respondents dwindled to less than 5 a month. 2015, that was the end of the funding, that particular project. That was the ending of the electronic tool. That was the ending of self-management. That was the ending of the data. That was the ending of engagement. It was project-based. There was no sustainability plan. People got gung-ho. They bought into the project. They were engaged. And then they just drifted. I've seen that happen a couple times. So this is one good example of that happening. Did we learn? Yeah, I learned a lot. A couple of really, really good lessons learned. We'll come back to highlight some of those again in the end. And one of the key things that came out of this is our minister looked at this project and said, that looks really, really cool. And took the idea and spread it across the entire province of Ontario. In 3 years, it became 80 programs with entire population coverage. So that's spread and scale. So this innovation happened. And we called that program in Ontario something called Health Links. People who follow Ontario have definitely heard of Health Links. It's been written up in some of the journals. December 2012, it was announced. Some programs got named in 2013. Really a new model of care to improve care for high needs patients, also based on some of the work that I'd done in high needs patient populations. All providers working at the local level to design low rules. We tell you we need better coordinated care. You figure out what that means. I said it needs to be local. That's a little too local. That didn't even really have vision and goals. Come back to that. We did a quantitative and qualitative study. We were the central evaluators of this program. We do a lot of this kind of work for provincial scale programs. And I'm going to talk about one region of the province that had 3, it was an early adopter region with 3 hospital-based. It was probably one of the stronger early implementers. And we did some evaluation on that. I'm going to give you some results of that, both quantitative and qualitative data. Not really mixed, but multi-method. It was low rules and patient implementation. So there was no frontline patient experience data. Not like in that PATH project, we had like real live patient experience data all the time. We had none for Health Links. There was no logical model for the intervention components, except that there is going to be a provincial coordinated care plan. So they designed, said, here's the coordinated care plan, here's what's on it. Best thing about this whole thing is on page 1, it asks about the patient's goals. Everything else is probably a waste of time. But that was it. That's what we knew. You know, everybody was going to complete one of these coordinated care plans, and that's what they were going to measure. How many coordinated care plans did you do? And that's the report that still exists today, 6 years later. How many coordinated care plans are completed? We do have 1 or 2 new measures around people's confidence that were just introduced this year. One region with the registry of enrolled patients, which we actually thought everybody had done this. We took this model and we said, okay, now we're going to do it for the whole province. It turned out this was actually the only one place that we could do it. It's taken us 3 years. Apparently, we just got a registry in June with about 40% of the population at 27,000 observations. And that's taken several years of work. Very limited patient engagement. They will say patient engagement, but as far as I could tell, all steering committee membership. They have some good champions. Some good people grew up in this program to become strong patient engagement champions, but mostly steering committees and not necessarily representative patients. We did both a quantitative person-level outcome evaluation. So this is, rigorous comparative effectiveness evaluation, summative evaluation. And the question was, did outcomes of Health Links patients improve more than comparators? So not just what the programs themselves could do. Every program out there that I saw all said they had high healthcare utilization, and after Health Links, it came down. Yeah, I found that too. And here's what we found. So the matched comparators and the enrollees. And enrollees are shown here in the gold on the top. The comparators, so people who look just like Health Links patients in so many ways, they're propensity matched, are the blue line. And this is healthcare utilization leading up to when people actually did get enrolled in Health Links. And the people that would have been, they looked very similar. So you can see actually they look quite similar. Healthcare is going right up for these people, coming up to the point where we've identified them and gone, oh my goodness, you're using a lot of care, you're in the hospital, we need to take care of you. I've got total cost. We had, graph looks the same by hospitalization, emergency department visits. And then here's what happened to the enrollees after they got enrolled in HealthLinks. It worked. Their utilization did not continue to go up. It did not stay high, it came right back down. And here's what happened to the people that didn't get HealthLinks. It worked even better. So really, best thing we could have done is leave people alone. You know, we did this and we brought it to the ministry and we published it in CMIJ Open, and the ministry still came back and asked us to do another evaluation of another project. I thought that was pretty cool. Next project, way better results using the same method. So I was actually started to get worried that it was the methods that were driving this answer. Because they did it in a few other regions in the province and everybody got the same answer. But I've used it now in other examples, and you don't always, it's not the method that gives you this answer. That's actually the program. So why did this happen? So here's, we did 30 interviews in the same region, where there's three programs with leaders and managers covering the 3 links, and 24 surveys with leaders, and another 71 additional surveys with clinicians, mostly primary care providers in enrolled health links. And here's what we found with these interviews, and I'm not going to show much of the survey data except to say that, you know, I can tell you the further away you get from the center, the lower the ratings get on engagement and leadership. So some of the strengths: relationship building amongst core partners, people who had caring for the same people, never talked to each other, didn't even know each other's office numbers, were actually coming together to plan and coordinate care for these people. Never happened before. Good start. Case conferences, when they happened with the teams, and you actually got people around to talk about what was in that coordinated care plan, everybody thought that was really great, but it was pretty sporadic when that happened. Generally speaking, what happened was the coordinated care plans were created by one agency and not shared with others. One care coordinator went in, did an assessment with somebody, filled out the form, came back, took a scan of it, maybe faxed it off, maybe didn't know where to fax it to, put it in the file, and the coordinated care plan was done. Check. One more. There were some difficulties in who exactly should be getting these coordinated care plans. That's a patient identification. These coordinated care plans, as far as I can tell, never saw another update on them, how they were being done. It was just about getting them done. A couple of physicians who were initially engaged drifted away, and they were often not included in case conferences. Most saw very little difference. 20% of physicians in our survey reported never being involved in care planning, and 45% rarely or sometimes. I'm not going to have a long talk about physician engagement and decision making. Physicians are, you know, less than 15% of the workforce, but they're making 80% of the decisions for which way people go in the system. They're really important navigators. We need a lot. It's not just about physician decision making, but when they're not there, it's a big gap for us. Information sharing was totally stymied by a lack of interoperable IT and people's foundless privacy concerns. I'll say that. And the performance indicator most people felt didn't reflect the goals of HealthLinks. We want better coordinated care, and we just ask if you've got a plan completed. And I had the ministry ask me, say, what's the value of a completed care plan? And I said, 0. But if you actually deliver on the care and change the plan and reorganize people so that they're not seeking care through the hospital, and you give them substitutes and you provide alternatives, then it's probably 50%. But just the care plan on its own, the way it was done here, I think about 0. Coordinated care plans alone are not enough. It takes a team to implement coordinated care for a patient with complex health needs. And optimally, only 30% of the population of Ontario possibly have access to a team. We have pretty good access rates to primary care. I know primary care access is a big issue down here. But we have pretty good access to primary care. But only 30% have a team. And I think, health links, you're only as strong as the weakest link. Healthcare is a weak link game. It's not about your strongest player. It's about your weakest player. And this is one of our weaknesses. And we couldn't actually possibly deliver on coordinated care without teams. So, third example, our efforts to build and work in team-based care. And this is where we're currently at right now. So I'm reflecting now on a few of the lessons we've learned from the last 2 into this new one. We try to learn as we go. So this is a team-based care model. It's pretty low tech. We have, like I said, 30% of our province have access to Teams. What we've done is there are a number of initiatives advancing access to these teams for people not in the teams. And we worked very closely with the government. So deliberate outreach from the teams to non-team physicians. So go out and talk to the solo physicians in the community and let them know, we're willing to take a couple of your patients that you think have complex needs, and we can co-create some care. Not a referral and we take care of your problems. No. This is about participation and engagement. And using communication as a mechanism to build relationships and trust. So we have our first 2 markers. People have said, so are you going to look at emergency department visits or hospitalizations? I said, no, I'm looking at 2 things. I'm looking at the number of people who get referred into the program by the physician, and I'm looking at the number of communications that flow back and forth between the team and the physician. To me, those are the 2 most important starting metrics. And the other thing we learned here, so I can go back to my PATH project where we did all this data, we sent it out and nobody beyond the project team used it. I'm like, I'm not doing that again. Like, we put a lot of work, over a year and a half producing weekly reports, and I think not one of them got used. A monthly report, that was a monthly stat, got used in the annual report. I said, we are not sending data unless somebody there says, give me the data. And so we need practice facilitators, people who are there to actually take the data and work with the teams to make sure it goes to the teams, the providers. And so we are only working with places that say they have that resource and have that resource with that skill set, and they have access to the providers. We wasted a lot of time on the other one. So, we learned. So maybe we didn't totally waste time. We know that we don't do it unless we have that. And designed a program that worked in 4 regions to open team-based care to non-team physicians and their patients through various initiatives. So we have 4 of these. And actually, we did this, and then the province announced some additional funding for interprofessional team care with the idea that it was expanding access as well. And those other people got money, and 8 of those other programs, some of which are actually better than our sites, have come to us and asked us to help with their evaluation and share resources, share our evaluation models and methods with them. And we said yes on one condition: you have to have a practice facilitator. If you're doing it with that one. I think originally 8 teams came to us and 4 of them have facilitators, and so we're working with 4. We've learned a couple of enablers, and this actually comes from Arctic, which is a program in Ontario between Health Quality Ontario and the academic teaching hospitals. They've actually got some pretty good resources of, if you want to go and implement things, you need a couple of things. One, you better be implementing in an area that's aligned with strategic direction. Otherwise, you're going to be on the corner of the desk. You need executive champions, and you need to have some governance for sustainability. You don't have to have governance right off the top, you need some. You need communities of practice to support this work. People need education and training, what it's all about, that they can actually use your data, that you can feed it back, and that there is continually audit and feedback loop. People know how they're doing all the time, regularly. And this role of the facilitator, supporting the connection to practice. The main objective is to build relationships, enable communication, and share data. The goal, to create greater integration rather than change organizational cultures. We're just going to partner, create ways that we partner. We're not going to come in and change the way you work. We should create new ways of partnering. And relationships and trust is critical. So a couple of my experiences, I think I can summarize here. We have had provincial ministerial support for this program. For facilitation, the ministry's actually funded facilitators in a couple of the regions. Providers want to better care for patients, but slow to change practice. It's still slow. That's okay. Be patient. Patients have been very helpful in moving providers along. We've had things like, we want to get out and do baseline surveys with people about how coordinated their care. And they're like, we have mental health patients. They're not going to answer this survey. They're not going to work it. We're like, okay, well, why don't we go to your patient council and talk to them about what the tool looks like and their involvement. We had patients involved in every local steering committee, but we went just to the patient councils, and they're like, oh yeah, no, this will work. And I think you can do it this way. And do you need some volunteers to help out? And then we took that back to the providers, and they're like, oh, okay, I guess we can do it. But patients have been very helpful in solving our problems, all of our problems. Like lots of other experiences in the past couple of years about how having patients involved and part of the decision-making, providers, they come up with all kinds of things that they think patients want and don't want. And when you put patients in the room, all of a sudden that goes away. Evaluation is very complex with different forms of intervention, different scale, and heterogeneous partners designing local interventions. That's life. These aren't clinical practice guidelines. These are local contexts with different people, different personalities, different resources available in different communities. And that's the space of moving ahead in this space of multiple chronic conditions. Couple quick things: have a clear logic model, have executive and frontline champions, use practice facilitations, communication and problem solving. I've said all these things all the way along. Essential practice is my last 3 points. Effective partnership requires understanding what the other partners want. You want patients, providers, caregivers, researchers. Like, you really need to understand each other. And how do you get there? The most important way to communicate is to listen, to ask. I find anytime I'm asked for policy advice, I go in and I listen. What's their question? What's their problem that they're trying to solve? I'm not pushing my research and saying, hey, I got this great idea, you need to implement this. That's not the way things get adopted. And we have a lot of practice change happening in Ontario. You know, we've basically got millions and millions of dollars. In fact, I'd say we've been quite influential in new legislation that's been passed in Ontario to implement Ontario health teams, which is a totally redesigned system. And that's because we listened. And then when they had a problem, they came to us and said, what do we got to do? I said, you need to implement integrated care. So that's what they're trying to do, province-wide, in legislation. That's a signal. And obviously we fail. We fail. And so every time we fail, can we fail forwards? So when we stand up the next time, we're further ahead. We're going to continue to fail. We gave a talk on Friday. We had a whole day about Ontario health teams coming out, and we had all these, people way better speakers than me. I was the B-list guy for sure. And at the end of the day, gave a little, this is what I think could look like, really great vision. People are like, oh yeah, this is great. It's great excitement. And you know what's going to happen? We're going to fail. But hopefully we can fail forwards and pick ourselves up. And that would just be where I'll leave you with. Thanks. So take questions, I think, right?